I'm Aubrey Rhodes. I am the Executive Director for the Lung Cancer Research Foundation. And our mission here at LCRF is pretty simple. We fund research to improve patient outcomes. We are actually in the process right now of going through our scientific review of letters of intents from grant applications. We received over 220 applications, so we are thrilled to be going through that process right now and selecting some of the best science that we'll fund later this year. So we also believe that research is only as good as the informed patient. And so our programming today is really intended to ensure that you have the latest information on scientific advances. So we're going to cover a wide range of topics, everything from biomarker testing and navigating clinical trials. So we hope that you'll find this live talk really a meaningful experience, and hopefully you'll take away some valuable information that can help you through your own journey. Before we get started, I will just share with you all that on May 15th, we have a couple of educational events. We have an in-person event that'll be taking place in Chicago, where our Chief Scientific Officer, Dr. Wozniak, will be moderating a discussion among Dr. Fiedler from Rush, Dr. Bespina, and Dr. Tawani from University of Chicago. That will be a conversation very similar to the one today, just in person. And then we also have another live talk together separately that'll be taking place right here on May 15th with Dr. Nargis Flores, where we'll be focusing on women and lung cancer. So both registration links, I believe, are in the chat or will be going in the chat pretty soon. One last thing that I will share with you, I hope that you'll save the date for our Free to Breathe Walk weekend. It's taking place October 5th and 6th. And this is really just a lovely way for you and your family and friends to kind of team up and come together to raise awareness and support research. It is now, I guess, my pleasure to introduce to you our moderator and the chair of LCRF's Education and Engagement Committee, Dr. Isabel Preeshagul. She is the attending on the thoracic oncology service at Memorial Sloan Kettering, and she's actually been working with LCRF for a couple of years now, and I had the opportunity to meet her in person for the first time just this past weekend at one of our in-person events. So thank you, Dr. Preeshagul.
Thank you so much, Aubrey, for that very kind introduction. It was wonderful to meet both you and Courtney and to see Morgan and Dennis and the whole team at our Together Separately in-person event this past weekend. And I am thrilled to have yet another Together Separately event within a matter of a week. And we are joined by a very dear friend and someone that I've worked with previously on many different avenues, Dr. Julia Rotow. She is a thoracic oncologist at the Dana-Farber Cancer Institute. She is the clinical director of the Lowe Center for Thoracic Oncology and an assistant professor at the Harvard Medical School. Her research interests include the development of targeted therapies for the treatment of oncogenic-driven lung cancers. Julia, it is so wonderful to have you here today. Thank you so much.
Hi, Iz. It's really great to be here and looking forward to the conversation today.
Yes. So as Aubrey had highlighted, we're really just going to talk about the patient journey, right? So what is it like when you first get diagnosed, to your first meeting with your oncology team, to how to navigate all of these difficult avenues and to learn to speak a language that we all speak fluently, but you are just learning how to say hello. So let's start a little bit about how do you think you would advise a patient to make the most of their first consult with you, whether it's an early stage, advanced stage patient?
Yeah, and I know that at first visit, I feel like the most common way to feel amongst many strong emotions I know is overwhelmed, right? There is so much to be thinking about, so much to be taking in, and so much unknown and uncertainty and new information. So it's a hard, it's a challenging visit, and I think, like you said, I think some preparation can help you get the most out of it. And what I usually tell people is, one, to go into that first consult, come in with a list of questions. That can be a really great way, as you're going through prepping. I have a lot of people come with a written list. I think that really helps when in the heat of the moment, it's so hard to remember what maybe you were hoping to talk about, and having those topics or those questions, I think, can be really helpful. The other thing I remind people is that this is the first meeting of many meetings. So there's many opportunities to have more questions or to have things that come up along the time. Or if you think about something later and you wanted to know more, it's sort of the first of many conversations. And that can help sometimes with taking the pressure off what I know is a busy first visit.
Absolutely. And obviously, it's very difficult to advise this before, you meet the patient, but typically we say it's always good to have an extra set of ears with you, right?
Yeah, I would agree. Having a friend or family member or just someone trusted to come listen in, again, they'll remember details that, you may miss, and vice versa. They can help bring questions. They can offer emotional support. They can be a ride when it's a hard time to be trying to drive yourself. So all these things, they can be so helpful for, and most people, a lot of people will come in with someone. Doesn't have to be family, can be anyone who might be able to help them as a extra set of ears.
Yeah, absolutely. And it's also a nice opportunity to introduce, this very new patient to the care team and like the collection of doctors and nurse practitioners and nurses that may be caring for this patient. So who's typically part of a care team at Dana-Farber for you?
Yeah, and it's actually a pretty good number of people, and the idea is to have support across multiple different domains. So the first person you might think of, in addition to your, the patient, is the physician you might be meeting with, and that's of course a very important relationship. But we also have nurse practitioners who are oncology nurse practitioners who are a really important part of the team. They'll do some of your visits at Dana-Farber is at many sites, and they also have an established relationship with each patients. You'll see the same nurse practitioner again and again as you come back to clinic. But beyond that, we also have our nurses, sometimes called nurse navigators, who are also a great point of contact if you have a quick question, or we're thinking about managing symptoms, or something comes up where you need to talk to someone in your clinical team in a very short term. They're a really fantastic resource. Beyond that, there's the infusion nurse, and many of the medicines we talk about giving for cancer are IV medicines given in our infusion centers. We try to maintain a relationship between our infusion nurse and our patients as well, and that can be a really important source of support and knowledge too. And beyond that, of course, we have the social workers, nutritionists, and all the other members of the team who think about all the other elements of health and well-being during the course of cancer therapy. And we step even one step further. We have our social workers who can help with accessing community resources, help with sort of supportive counseling, and even support as well going forward.
Yeah, I mean, it's a family, which is what I like to kind of say. We are your family outside your family. And I think you described it so beautifully, and you always just want to make sure that like you have a point contact and a phone number for the patient to reach you reliably, and for you to reach the patient, or someone that's just going to pick up their phone no matter the time, blocked number, whatever.
It's such a great point. In the modern world, who answers their phone, right? Like no one who answers their phone in real life from a number you don't recognize. But we need, we want to be able to reach you and get in touch, and having a strategy for that'll work can really help speed communication.
Yeah. So I know this is being recorded and a bunch of people are on the line right now. Could you give some suggestions of sample questions that you think a patient should come with prepared to ask you, or anybody that they see at their first visit?
Yeah, I'm thinking, and I think that visit often comes, maybe you've heard about a cancer diagnosis from other doctors, maybe done an initial biopsy, and you're coming in for that first conversation about it. And, I usually encourage asking some very practical questions first. I usually suggest asking things about, should I have any more testing? That's a good question. So for example, have you had all the right imaging tests that you need? And has your tumor has all the testing it's needed? If you've been under treatment for lung cancer, you know that we often do a lot of biomarker testing on the tumor cells themselves to understand what's the best treatment option. And we don't always rush into that first dose, although it feels like such a rush to get started. We want to make sure we get you the very best, most effective therapy possible. So asking, does my tumor need any more testing, can help remind your doctor to think about that, and help start a conversation about what maybe could be done. I always also recommend asking, could a clinical trial be a good idea? When we think about all the standard treatment options, and there's lots of increasing and improving standard treatment options, but a clinical trial can be a great option too. And if you ask, that can sometimes spark a conversation that may add additional interesting treatment options you may want to consider. And I think those are key ones. Last thing I'd suggest is asking, some practical questions like, how long are these treatments going to take? How long will I be on therapy? Is there an end date to treatment? These sort of questions can help with planning from right from the beginning. Yeah.
I think those are great points, and you really broke it down very nicely. And I think sometimes there are some more difficult questions to talk about at these visits, and some patients prefer to get them addressed right up front. Some patients prefer never to address them, and sometimes the room is split, and you have one family member that's really kind of probing at that, what's the prognosis question, and another one that's like this. So,
yeah, and I
how do you
dodged
handle
that
that?
question. Yeah, I dodged that question. I think it's fair to ask, what is the goal of treatment? Sometimes the goal of treatment is to completely get rid of the cancer or cure. And sometimes the goal of treatment is more aiming for cancer control, thinking about maintaining control of the cancer on ongoing therapy. And that can be even if you don't want to know long-term prognosis questions, that can be a safe question to kind of get a sense for what is at least our goal of this treatment. And I agree. I think some people want to know more about prognosis, and it's okay to ask, and your doctor will do their best to give estimates, but it's okay to say, I don't want to know those things, and to be open about that conversation too.
Yeah, I agree. I think it can be very difficult to explain the goal of someone's treatment without, taking away hope, right?
Yeah.
So you had said it so beautifully that we're trying to control your disease, which is something that we might share with a patient that has stage 4 disease, or sometimes I say we're going for a marathon, not a sprint. This is treating you more like a chronic thing, so this is going to be ongoing indefinitely. But I do think while those things are difficult to hear and challenging to discuss, it's important to know that, because I can't tell you how many times I've seen patients for second opinions or third opinions, or even patients that I've seen myself in clinic where I believe I have been clear, but maybe I haven't. And the patient is like, oh, I'm done with my 4 cycles now. Like, what, am I good?
Yeah. I never want those kind of surprises, right? Like, I think it's being very open, honest communication right from the beginning can be so helpful.
Definitely. And you brought a beautiful segue to clinical trials, which you mentioned, which I think historically speaking has been thought to be a sort of a last ditch effort, which is by no means how you work in your clinic or we work, in my clinic either. How do you sort of introduce the concept of clinical trials and provide comfort and kind of, I guess, sort of spark interest?
Yeah, and I hear that a lot when I bring up the word clinical trial. People say, "Oh, isn't that a last resort? Isn't that?" And I think there's that misconception that it's maybe the thing you do when there's nothing else, and that's really not the way modern clinical trials exist. There are a wide range of different types of clinical trials, and some of the drugs that have been given to hundreds or thousands of patients before, where you know a lot about this potential drug and what you know about side effects and an anti-cancer effect. And some of these we may even be studying as a very early treatment, even as a first treatment for cancer, where we hope maybe we can augment or improve upon whatever the usual standard treatment is. And there are clinical trials all the way on the other end of the spectrum, where maybe a drug is newer and there's good science behind it. We don't yet know as much about its effect for a person who might be taking the drug. And there's trials all the way in between those different categories. So we use trials as our go-to first treatment for some folks, or as our recommended first treatment. We use them as a second or third treatment. That's very, very common. I think a lot of interesting things happen in that second or third treatment option. And then we have trials that are meant for use later on. And usually if you're going to access something like that, seeing a doctor at an academic center, they can help tell you what's known about the drug, about the trial, where is it in development, and would it be a good fit potentially.
Yeah, I think that's a perfect segue to my next question, just to kind of talk about briefly a clinical trials 101.
Yeah.
Could you break down, and we will get to that question, but could you break down like what is phase 1, what is phase 2, what is phase 3, and how that might look like for a patient?
Absolutely. So I usually say for clinical trials, they're traditionally broken down into these 3 phases, where a phase 1 trial is the very earliest type of trial that's run for maybe a new potential drug. And that trial, they're often studying things like what's the best dose to use? Should the drug be taken with food or not? They're trying to get a better sense for what we might expect as side effects on the drug. These drugs all go through very extensive pre-human testing, where we have a good sense of what to expect, but these are earlier in development. Phase 2 trials are often larger trials where maybe the focus is still watching for side effects, maybe still making sure we're happy with the drug dose that's being used, but the focus is really shifting towards looking at the effect on the cancer cells. So maybe there'll be a larger number of patients being enrolled all at the same sort of dose to get a sense for anti-cancer effect. And then phase 3 trials are often the largest phase of trials. These are often very large trials that are run right before a drug might potentially become an approved medication if all goes well in the study, or might be a randomized trial, which means that some patients in the trial might get one treatment and others might get something else. Often that's the new treatment versus the standard treatment, or the standard treatment versus standard plus the new treatment, something like that. I always like to be really clear that for these sort of cancer therapeutic trials, some will have placebos, but never a secret placebo. So if there's a chance of getting maybe a fake medication in addition to the standard medicine, for example, you would know that. And that would be part of a discussion of the trial. And that's a very important enshrined function of any research ethics. I mentioned that because people often ask me this: could there be an arm where I'm not getting treatment? The answer is no. That's not something we do in the modern world. And then the other thing I like to talk about is, what does it mean, or how would you actually end up on a trial? What's the process like? And usually what that involves is a conversation with a doctor at the site where the clinical trial is being held. And if all sounds like you might be interested, you would sign a consent for the trial, which is a big, intimidating thick document in some ways. And then you would go through what's called screening, where you go through a series of tests to make sure that your health is well enough to participate in a trial, that you seem eligible for the trial. And that's often things like a set of blood tests, or making sure your scans are up to date, or checking in on heart health, things like that. And then if you actually enroll, you would start treatment. Then you'd be treated on the trial protocol. There's usually a set schedule of visits with a set of testing, where they're trying to make sure that the drug is given the same way to everyone, but also that your safety is being appropriately monitored. And we have a question: what does the placebo mean? I can mention that. For a randomized study, often they're trying to figure out what effect does this drug really have. So there might be a standard treatment, and they want to know if adding the new treatment to the standard treatment could be better than the standard treatment alone. So they might randomize people, have to get both together, and have to get the standard treatment with something called a placebo. And that's like a fake medication, like a fake pill that actually doesn't contain the study medicine. And you'd be told if there was a chance of being randomized to that. And the idea is to get a really good sense of what effect does the actual medicine have versus thinking that we're on the medicine. Yeah, and sometimes even the doctor treating you doesn't know which one you're receiving. So we're not biased either. We don't assume side effects or because of the drug, because we don't know.
Yeah, and I think you mentioned about, how to monitor these patients on protocol. And I think a misnomer is that patients think once they sign on the dotted line, they can't stop, right? They're just committed. But basically, you can withdraw consent at any point. You can sign and withdraw the next moment. You can withdraw if you can't tolerate it. Your quality of life is just not working out with you. You don't like the team. Even if your scans are beautiful, you can come off at any point. But if you're not tolerating the treatment, right, or your scans are not looking so great, the trial you will be taken off the trial, and other options will be discussed at that time. So it's not a one-way train that you can't get off of.
Exactly. Any clinical trial, like all treatment, remains voluntary at all times, and up to you fundamentally is the most important decision point. The other thing I get asked is, well, what's more important, the trial or my health and safety? And the answer is the patient's health and safety is always the most important thing. So if there's a conflict between the trial protocol and a patient's safety, it's the patient's safety that matters most. And that's a really important point in any trial as well.
Absolutely. And just to kind of segue in one of our questions, I see the chat's coming alive right now, but there's a question about tissue-based next generation sequencing testing versus blood-based. And oftentimes we use this to help determine clinical trial versus not. Could you talk to us a little bit about those two testing types and answer the question?
Yeah, so I mentioned briefly the idea that at a new diagnosis, for lung cancer in particular, our first treatment that's given when we select among many different options is very personalized. There's no one size fits all first treatment for lung cancer, and it can be very different from person to person, depending on all the details of your health and all the details of the tumor. And among those details of the tumor is the tumor's mutation profile. And this is the DNA changes in the tumor that may trigger us to think that particular treatments might be an option or not. So knowing that mutation profile is really important, and we profile most forms of lung cancer now at diagnosis. Now, there are two different ways to test for it. There's tissue-based testing and liquid-based testing, and many of us will even do both or do one followed by the other. And tissue-based testing is when you actually submit a tumor biopsy sample and kind of get the DNA out of those cells, and then you run the test on them. Liquid-based testing is where you just take a blood sample and you're looking for tumor DNA that is shed into the blood, and then trying to pick that up out of the blood so and then test that. So you could imagine the testing on the biopsy is much more sensitive because you're actually feeding the tumor cells themselves into the test in some ways, but it takes a lot longer to come back. It can be a several-week test, even as many as 3 weeks. And that's hard when you're waiting to get a result and maybe your biopsy is too small and now you're waiting longer, and that can cause delays. Blood-based testing, as you might imagine, is a little less sensitive because you're relying on enough DNA shedding, and sometimes there just isn't enough DNA shedding to test, but it can come back a lot faster in as little as 1 to 2 weeks. And if you can get an answer out of it, you can move forward with treatment more quickly. So my own practice, I'll often send both in parallel, sort of 2 shots on goal, so to speak, trying to get the data we need to get a treatment recommendation. And this is most important at new diagnosis. But for some people along the way, depending the treatments you're on, you might need repeat testing if you're on a treatment that we think might impact the mutation profile over time or cause it to change in a way that impacts treatment options.
Beautifully said. And I thank you for, breaking that down. So I guess to sort of recap, it's really important to advocate for yourself and ask your oncologist, even at the very first visit or any subsequent visit, have I had next generation sequencing testing on, blood-based and tissue-based? Like if I haven't, can we arrange that and make sure that it's done? Because while it's standard of care in stage 4, and it's really moving towards being standard of care in the early stage setting, it's not being done appropriately across, across all treatment sites, regardless.
Yeah, it's so
that's another
important.
issue.
When they study this, I mean, we know that not everyone who should get tested is tested. And some of these therapies that come out of that testing are really effective, really well tolerated, can work for years. So it's really important not to miss those options. Now, it's not that all tumors need to be tested, but I think asking that question, and next generation sequencing is that most comprehensive form done on a tumor sample. Asking that question can help make sure that you're prompting your doctor to think about, well, have I done that testing, and make sure it happens if it didn't.
Yeah. And that's a good question about what material or what tissue is best to pick up on these alterations. And there's a question about pleural-based testing in the chat, and I think sometimes bone does, how effective is bone? So what are your thoughts on different, materials for testing different locations?
Yeah, you want, ideally you want a good biopsy sample that's big enough and of what's called a soft tissue lesion. So that's like, a spot in the lung or a spot in the liver. And those are most likely to be successful. I picked those at random, but non-bone lesion. Bone metastases are a little harder, and they can sometimes still be run successfully, but there's some complications because it's a little more of a harder spot to run the test on. So sometimes they're more likely to fail and need to be redone on a different biopsy sample. So it's sort of our last preference when it comes to choosing a spot to try to sequence. So ideally, if your doctors are thinking about a need for sequencing from the beginning, you can pick a biopsy site that might give a diagnosis and allow it for use for sequencing testing. The other challenge is very small biopsy samples. Sometimes people, they come in and they were diagnosed before meeting an oncologist, usually, and maybe their biopsy samples are really, really small biopsy that's just too small to do testing. And then you have to do a new biopsy, and no one wants to do extra procedures if it can be avoided.
Yeah, I absolutely. Highest yield always first, highest yield, lowest risk. The question is specifically about pleural fluid. And I think the challenge with this is to make sure that there's a good enough cell block. So basically they take out that big, bunch of fluid, and then they spin the cells down, and all of the cancer cells, if the fluid is considered malignant, collect in this, what we call a cell block, or like a blob, I imagine. And then we run the next generation sequencing testing on that. But if there aren't enough cells in that fluid and you don't have a good cell block, it can be difficult to run this next generation sequencing testing. And you need like at least 15 to 20 unstained slides, which is, 15 to 20 untouched slides for them to run this testing on.
Yeah, and certainly it can be done successfully on pleural fluid. I know a common presentation with lung cancer is fluid buildup around the lung. It's called pleural fluid. And that's often drained to help make breathing more comfortably. So I always, if I need to, I'll try sending it on that. If I need to do the testing, it's just a little more likely to fail than a regular biopsy sample. But if you have it, it's reasonable to try. And sometimes it can work. It's just hard to predict in advance if there'll be enough cells.
Yes, definitely. And I will get to the question about palliative treatment, but I see that there is a more personal question about a clinical case, about a patient that unfortunately has stage 4 disease and progressed on frontline osimertinib, followed by gefitinib. So a 3rd generation TKI followed by a 2nd generation TKI. And now the cancer is progressing on that 2nd generation TKI. And the next line of therapy that was recommended was carboplatin pemetrexed plus amivantamab. So here is a perfect example of next generation sequencing sort of coming to fruition. And I guess this family is curious about what your thoughts are. And just as a disclaimer, it's very difficult to discuss personal cases without having all the information and without seeing you and examining you. So everything that we talk about is really broad, and maybe these are questions that you can bring back to your oncologist, but by no means are medical advice that that you should follow suitly. Your medical oncologist is your oncologist, and we are here to kind of guide you, and maybe you can write down some questions to bring to your next visit. But Julia, after saying that, what are your thoughts about someone that's progressed on OC and progressed on gefitinib? What are your thoughts about next lines of therapy for patients that harbor EGFR alterations? And I'm assuming this is exon 19 or exon 21 L858R.
Yeah, and I think for EGFR mutations, those are most common of the gene mutations we find in lung cancer that has a pill that goes with it. The pill is called osimertinib, and gefitinib was an earlier generation of EGFR targeted pills as well. After those kind of first targeted therapy stops working, my preference whenever possible, in addition to repeating that molecular profiling, I mentioned this is one scenario where we like to repeat profiling. Sometimes we pick up new mutations that might have other targeted therapies that go with them. But absent that, my preference at that point, it's a good time to look for clinical trials. If you might be eligible, I think a lot of things that are further along in development, maybe have more data available or more information available, are being studied, for example, right after osimertinib, at osimertinib resistance. My preference there is a clinical trial if I can find one. Now, not everyone is eligible for clinical trials. Sometimes various health issues can stand in the way. Clinical trials often have a pretty high bar. They're pretty picky about how you're doing, because they're worried if you have unexpected side effects, they don't want to cause you harm with something that we don't yet know its net chance of benefit for the cancer with as great a certainty. So they have a kind of a higher bar than standard treatments. And some people just have other health conditions that prevent trial enrollment. But if they think you're not eligible, it's always worth asking, well, why? Why is the reason that they might not be eligible? And they should be able to have that conversation. Trials all have very different enrollment criteria as well. So eligibility to one trial doesn't always impact eligibility for another. They're all different. But they all have some basic shared criteria, usually requiring general well-being and health, for example, being up and about during the day, things like that. Now, for after osimertinib or gefitinib, these sort of things, in my opinion right now, our next go-to thing for most people is thinking about the chemotherapy amivantamab combination that's had some nice data that's come out recently. And I won't delve into that here, except to say that it was good data. It was better than chemo alone, though at the cost of increased side effects. So really talking with your oncologist about how much benefit was seen and how much increase in side effects was seen, and trying to balance for your own self, does that risk-benefit ratio come out in favor of the combination therapy?
Yeah, I agree with that. I think, it's always nice to see something that we can give patients after progressing on osimertinib, because we're all just kind of sit here with egg on our face when that happens. And I think I totally agree with you. I think first and foremost, I would ask your oncologist if there are any clinical trials that are available at the institution where you're getting treated, or if they, you can also look on clinicaltrials.gov to see if there's any clinical trials that are in your capture area, or you can call out to large academic centers to see if anyone would be able to see you telemed to kind of talk about options. This is the time to get second opinions, talk to other people, and reach out just like you have here. There's never any hard feelings. And if there are, then it's certainly not the right fit. We always want what's best for you. So talk about trials, ask about standard of care options, and And there are many other options and lots of different things you can do. Just need to make sure that the sequencing is done in the best way possible. There was a question about palliative treatment, and I think this term palliation is kind of complicated because sometimes we palliate patients that are getting treated for cure because they're having post-op pain, and we want to offer something to palliate that or make it better. But I'm getting the sense that palliation, you're talking about maybe how do you address palliative treatments when you know that the client believes that you are their last hope? So we're talking about somebody that may not be doing so well. So how do you handle somebody that's seeing you as a consult that has progressed on multiple lines of treatment, and maybe you're really looking to kind of focus on best supportive care?
Yeah, and it's a good reminder of the need for continued research in lung cancer, right? Where we don't have our treatments, while they're much, much better than they were 10 years ago, even better than 5 years ago, and that progress is still not enough. And we still, eventually get to the point where maybe we've gone through the treatments that we think have a really meaningful chance of benefit. And, when I say benefit, what people are often thinking about is feeling better and having more time where they feel well. And of course, that is different for everyone, what they're looking for out of treatment, but that's often what people are looking for. They want the most time feeling well, where they can have good quality of life. And sometimes the way to get that is to do more treatment, say more chemotherapy, more other things like that. Sometimes if we've gotten to a point where the remaining treatments are unlikely to be helpful or likely to be harmful because we think they're just going to cause side effects that are trouble, sometimes the best way to have more good quality time is to focus on what's called palliative care or best supportive care, where instead of focusing on the cancer medications, we're focusing on symptom control and symptom management and side effect management. And we know that really careful attention to that can help people live longer as well by feeling better. When we start talking about, we call it best supportive care as our term, but really palliative care without additional cancer treatments. We often have our palliative care colleagues involved. These are doctors whose focus is in symptom management. They are often involved much earlier. I usually encourage people to get involved with a palliative care doctor very soon after diagnosis. So this is not something that's only offered when maybe we've exhausted other standard cancer treatments. But as you get to that point, this becomes even more important, trying to help make sure everyone feels as well as possible for as long as possible.
Yeah, absolutely. And I hope that answers your question.
Yeah.
There's another question in the chat about when is it appropriate to go for a second or third opinion?
Yeah, and our usual rule is if there's any time where you're feeling uncomfortable with your treatment plan, I think a second opinion is a reasonable thing to do. I think most oncologists, I think we all are very happy to hear the opinions of our colleagues. I think as you said earlier, if your doctor ever doesn't want you to get a second opinion, well, that's a problem. And, that would worry me about your doctor. So I think a second opinion can be really valuable. It can give your doctor additional things to think about, and it can give you peace of mind or understanding that you've really explored all possible options. Lung cancer is a serious diagnosis. So I often have a lot of patients who get a second opinion right at new diagnosis, just thinking about what's the big picture, what's the treatment program going to look like. And I think that's a very reasonable thing to do. And I think down the line, if you have to change therapy or if your doctors are worried about the availability of standard treatments, that's another great time for second opinions, and can help you look into whether there are additional options, clinical trials, or other ideas. We'll also say that I think we all get our oncology care in many different settings. Some people live near major centers, major cities, where they're going to large academic centers for all their routine care. But a lot of people also live very far away from major centers, where maybe you're working with more of your local oncology office or more general oncology, where your doctor might not be, say, a lung cancer specialist, but a cancer specialist. And that's, I think, a setting where, at least intermittently or at diagnosis, also getting maybe an opinion at an academic center can be really helpful if possible.
I absolutely agree with that. And I think just to kind of play devil's advocate here, I think the best time to get a second or third opinion is really also at any time.
Yes.
But you also don't want to get too many because sometimes that can be detrimental in the sense where it can be very confusing. It can be stressful, and sometimes it can delay care, which, you have the best intentions for yourself or your family has the best intentions for you, but you can't see Dr. X for another 3 weeks and your cancer is progressing and you're not feeling great. and you're just hanging on to that consult, sometimes that can be, that could be detrimental. So if you're, if you're not feeling well and you're in an urgent setting, that's one thing where I would, obviously no one wants to be in that position, but at least let the different, locations know that this is a little bit more urgent, that you're symptomatic, and maybe ask your oncologist to call out, to the oncology team that you're going to see. Because I can't tell you how helpful it is to have a doctor to doctor conversation, or doctor to nurse, or nurse practitioner, whatever it may be, to give like a quick turnaround. Because sometimes I can say, oh, Mr. Robert, he's not scheduled for another month. I'll move things around on my schedule. This patient should be seen right away. And the only way for me to know that is to hear. So ask your local oncologist to also get on the horn. It can't hurt. And we do it all the time for each other. We share patients back and forth. I have patients that go to Dana-Farber and come right back to me, and vice versa, all the time. So that's just one thing to know. And also one other thing to think about is your tissue, right? So some institutions need to confirm your diagnosis at that institution before they can treat you. And if you only have a small amount of tissue that had been biopsied from your original biopsy, and that little piece of tissue gets divvied up to multiple different institutions, sometimes you run out of tissue, and that can be a problem too. So it's just important to kind of take things into context, and just make sure that that you're not delaying your care, and you're not hurting yourself in the end.
Yeah, I
One other
agree.
question. Oh, sorry,
Go
go
ahead.
ahead.
I was going to say, sometimes there are multiple reasonable courses of action. And yeah, I think sometimes it's easy to get stuck between multiple different options. And I tell people the only wrong choice is not to make a choice, right? One of these, moving forward and getting started, or moving forward on treatment, so the disease can't progress and cause more trouble. So I absolutely agree with what you just said.
Moving on a little bit to talking about recommendations in regards to integrative medicine and alternative therapies. One of the most common questions I get, and I'm sure you get too, is like, do I need to cut out all sugar? Is sugar going to feed my cancer? And this question is talking about making changes to diet, specifically moving to plant-based and really limiting sugar intake. But they've never encountered a doctor who will explicitly address diet restrictions or recommendations. Is there any recommendation that you make for your patients in regards to diet?
Yeah, so I get this question a lot too. And I think, fundamentally, just in my opinion, right now your diet doesn't directly impact your cancer treatment response. And, beyond recommending a healthy, balanced diet, maintaining weight, and getting enough protein, just general healthy diet, getting enough micronutrients, all these things, we can refer to nutritionists who can help talk about your diet, make sure you're eating a balanced diet. Now, that's very helpful. But beyond that, sort of highly restrictive diets, unfortunately, we have evidence that those are going to impact the course of the cancer therapy. So my opinion is, unless you've got diabetes, but other than that, if you want a cupcake, have a cupcake if you need it to get through your cancer therapy. I am just fine with it. Cancer cells like sugar, but so do your healthy cells. So, and if that's what gives you the little boost in the day, I'm okay with that. Same with meat. I think meat is a great source of lean protein. I don't recommend, I don't know, bacon and processed lunch meats as your sole source of meat, but you don't have to restrict yourself if you don't want to eat these diets. Now, if you like a plant-based diet and you want to do that as a part of a healthy, balanced diet, you have the nutritionist guiding you, that's fine too. But I never want my patients to put themselves through some awful restrictive diet that's making them unhappy, causing them to lose weight, causing them to have nutrient issues because they're restricting their intake, because they're hoping that maybe by doing that, they're going to facilitate their cancer treatment.
Yes, now is not the time to go on some, crash diet or to completely alter your eating patterns. I fully agree. I just say, try not to lose weight, and just try to eat, because sometimes when you start therapy, like that can become a problem. And if you've already lost weight because, or you're malnourished because you've been juicing, or you read that, high keto diet is the best, or whatever you might have heard. I don't think there's enough data to support anything other than just eat a well-balanced diet.
And people have often already lost weight leading up to their diagnosis. It's a symptom of cancer. It can be weight loss that's inadvertent or unexpected. So all the more reason to focus on a good nutritional balanced diet as you go into treatment. And that definitely requires a lot more attention on cancer therapy than in normal life.
Yes, I fully agree on that. There's a question in the chat that actually is a very, Okay. Question about weight gain. And I don't know if this is weight gain on treatment or weight gain before treatment or during a diagnosis, but uh, I would say anything in either end, extremes is concerning. But Julia, I turn to you.
Yeah, I agree. My goal is usually to maintain a stable weight. Now, if you've lost a lot of weight and you are underweight, then working with a nutritionist for a healthy plan to regain some weight can be a good thing. But if you're at a healthy weight already, I really recommend aiming for stable weight on therapy. Can be a really good goal.
Yes. And also just to kind of divert a little, there are some treatments that do cause weight gain as a side effect. Sometimes you gain weight from steroids that you're on for other reasons, surrounding treatment or for toxicities that you've developed, and that can be an issue. But there are certain targeted therapies that are notorious for causing weight gain. So anytime you have a change in your weight, whether it's down or up, and if your oncologist or your health team doesn't pick up on it, I would share that with them uh, for certain. Um, yeah. So, and sometimes your weight changes and you gain weight when you start treatment because your cancer is responding and your body is sort of regaining all of the weight and the nutrients that it had lost. So sometimes it can be a very good thing as well. So I think it's a real case by case scenario. There's a question in the chat about sharing a phone number, a personal phone number. What are your thoughts about this, and how have you handled this? Have you ever
I
been
would say, I
approached?
think that's hard. I think it's probably a rarity. Partly the issue is, I think we have systems at our clinic to make sure that patient phone calls are received or patient messages that are received, that they're addressed by your treating oncologist or by their coverage if that person is out of office or traveling. And I think, going direct to the phone number bypasses a lot of that. So my own practice, I don't give out my personal phone number. I like to rely upon the resources we have in clinic. Now, doctors may vary on that. I think it's a very personal decision if you're comfortable sharing that. But I would say it'd be the exception, not the norm in most cases.
Yeah, I agree. And I think if you're ever feeling that urge to ask for your doctor's cell phone, the appropriate response that your medical team should have is there a reason that you're not feeling that your cares or your concerns or your questions are not being addressed timely? And if that's an issue, then maybe, that needs to be unveiled and addressed.
Agreed. And I will say that every clinic has a way to reach your doctor if they need to. It won't be a direct phone call, but there's always, I believe in all centers, there's a way to say page your doctor if something is medically urgent, and that would reach your doctor or their coverage if they're not available and not in a situation where they're able to, be directly practicing medicine. But there's always a way to reach out urgently if needed, and you're encouraged to use that.
Definitely. So we talked a lot about what your first visit is going to look like, things you might want to talk about, stage, goals of therapy, prognosis, what treatment's going to look like, clinical trials. But what if you have a patient that you've been with for some time, and unfortunately you have a scan that's not looking so good, or a patient that you treated for cure, and unfortunately they have biopsy proven recurrence? What does that visit typically look like for you, and what are some questions or things that a patient can ask, and what can they expect?
Yeah, and in some ways, that conversation has a lot of overlaps with the first conversation where you're taking restock of where things stand. What's the status of disease right now? What's the extent of progression? I think a good question is it just in one area versus in many areas? And the same question applies. Are we now treating again for cure? Maybe it's a very local relapse right near where the tumor was before, but the goal is to get rid of it entirely. Or it might be something where it's a more distant relapse where maybe the goals of care have changed. And it's important that you know that. And if that has happened, the same other questions also apply. Is there any additional testing that's needed? Is repeat biomarker testing needed? This is now a smaller fraction of people who need that at these sort of scenarios, but still can be important. A fair question, if it's been a long time, maybe you were treated with surgery 3-4 years ago and you've had a relapse now, which is unusual, but it does happen. You could ask, is there any new testing that's needed now that wasn't needed 3 or 4 years ago? Because as the field changes, what is needed for testing changes as well.
Absolutely. And I think making sure that that these testings are also covered is a whole other beast. And just to kind of shift pathways, I know that we are not as intimately involved with the insurance companies, but there are times we hop on the phone for peer-to-peer. I've definitely written letters to get drugs approved for patients before. if a patient runs into any issues with insurance, is there like, how does your team typically handle that? And what do you typically advise? What are some resources?
Yeah, and it's a really tough scenario because, of course, with so many different insurance plans, the correct path forward might be very different from plan to plan. Usually, if you're getting notified by insurance that something's not being covered, in most cases, they've notified us as well, maybe declined coverage. But this is, I think, best established things like medications, like if prescribing cancer treatments or infusions for cancer. We're probably aware if something's been declined and in the process of trying to appeal it, and we have our nurses and we have a group, a department in our institution that helps us sort of manage the issue of accessing drug when maybe we've hit barriers like cost of drug or insurance coverage to drug. The issue can sometimes be all this takes time. And I think perhaps the bane of all of our existence is sometimes insurance companies and their timeline for these sort of things. So you might submit an appeal and then they're going to take 30 days to let you know what they think of it. And sometimes you can wait and that's fine. And we do the appeal. Sometimes it's urgent to start treatment and we might change tack and say, let's do something else first while we work on this appeal. And that's a very personalized decision, I think, along the way. The thing I always encourage is, as part of this treatment, you're probably going to get a lot of different tests advised by your doctor. And, from a coverage perspective, making sure that you've been in touch with your insurance company as well, if needed, to say, am I in network? Am I out of network? What are the implications of doing care in one site versus another? Sometimes they can give you advice about impact of that on cost of therapy. I think we don't always think about cost or talk about cost when we're sitting face to face in clinic, but it's a serious real life consideration that has impact on the rest of your life as well. So, bringing up that transparently with your doctor and with your insurance company, I think, can be very helpful.
Yes, and there are also outreach programs, philanthropic funds, grants,
Yes.
and many different programs that can also provide drug for free. There's just an application you'd need to fill out and demonstrate, how much income you have in your household. But there are these programs out there and they're not advertised as well as they should be. So I really would, anytime you're put on a new drug by your oncologist, I would say, hey, are there any programs that can help pay for this? And if you don't know of any, can you put me in touch with someone in your finance department that I can talk to about this? Because I wish I could say that I'm savvy about this, but I'm not nearly as savvy as I should be.
Yeah, like we're warned if you're going to have, in our group, we get our drug off process going forward. If you're going to have an astronomical copay, a $3,000 copay that no one could possibly pay, I'm going to get notified of that so we can initiate the process. But for other copays, maybe it's a $200 copay and it doesn't flag our system. And maybe that's going to be an issue for you because that's still a lot of money to pay maybe every month. Letting us know that there's a problem with the cost of the medication can help us try to marshal resources. And sometimes we don't know that it's been a problem and we want to know if it's happening. Yeah.
Absolutely. And I think Courtney just put an amazing link in the chat. We have so many resources at LCRF that you can just tap into. So I would definitely go to the support@lcrf.org if you have any questions about financial assistance options. I think they're such a huge resource. To kind of jump back to our alternative medicines, and I know we're sort of rounding out time here. We have less than 10 minutes left. Do you in your clinic ever recommend, right off the bat, alternative therapies like marijuana derivatives or any serious side effects of that when taking it with chemotherapy? And when do you think it would be appropriate, or do you typically just refer these patients to supportive care?
Yeah, I think for cancer therapy, I don't recommend any alternative medicines. I'll put that up front. It's my own bias. I'm very data-driven Western medicine, but for symptom management, sometimes these things can be helpful. And marijuana for medical marijuana for symptom management is a state-by-state issue. So depending where you're living, be sure to look into your own state's rules around this. In Massachusetts, we have medical marijuana. So patients can get this with no prescription, no card. They can just go to a dispensary and access it. And, I think anecdotally, I've certainly encouraged my patients to consider that if they're having trouble with fatigue, nausea, low mood, low appetite. And my patients have told me they found it helpful. Usually what I say is to go to a nice dispensary, maybe in a nice town near you, and tell them you're looking for medicinal effect, not psychoactive effect. And a good dispensary should be able to guide you in terms of what to start with. I tend to steer people away from smoked products as well, just so I don't know what we know about the long-term effects of that on the lungs. As a lung cancer doctor, smoked products make me nervous. So, I recommend edibles and things like that as just maybe a way to get some calories in that. But so I've certainly had patients benefit.
Yeah, I agree. I think there's so many different ways to get these alternative products in, and they can be very, very helpful. But I always get this question of, is it going to negate the effects of the treatment? And I wish I could tell you with confidence, no, but I don't think we really know. And this should be an area that is developed. But I think the problem is that there's so many variations of these medicinal agents out there that it's impossible to have a standard, right?
Yeah, and I would encourage, if you are taking any alternative medicine products for anti-cancer effect or symptom management effect, most important thing is to be just upfront about that with your doctor, at least so they know what you're taking. Many of these things, we don't know everything about their interactions because they haven't been studied with the cancer therapies. But if your doctors know you're taking it or know that you're taking something new, it can help them maybe understand if they see blood test issues or other things. So, I just encourage you, even if it's something you're getting from a different source, just be upfront with your doctor and let them know, and they'd rather know than not know.
Yeah, I fully agree. And to kind of just round out things, I know we had talked about making sure that you have somebody with you at your new visits, and I really think at scan reviews it's really important because that's the time where you could have a treatment change. But how do you address caregiver burnout, and how do you keep an eye out for that to make sure that they have the right resources?
Yeah, and the caregiver role is a really hard one too. And I think we don't always talk about caregiver burnout. Many of the same sort of resources that are available for our patients in our clinic are also available to caregivers. So things like support groups, for example, can be very, very important. I think just like we tell our patients, now is the time to marshal the support you have in your community. Same thing applies to caregivers. Now is the time to marshal the support in your community, and it's okay to call upon others for help in that role, or to try to divide up the role, right? And who can I know sometimes there's one family member who is just, it's a continuous full-time job in some ways to be a caregiver, and people are Herculean and they're rising to that role, but we want our caregivers to have support as well. And in our own clinic, if we feel like things are really falling on one person, we often get our social workers involved as well, looking for caregiver supports as well as patient supports.
Yeah, I love how you said that, and I think the support group is a wonderful resource, but not advertised as much as it should be. There's another question in the chat, and I think we're going to try to wrap things up a little bit. In regards to cases, can the academic setting be utilized for clinical trials to help lower costs? And there's another question about medical marijuana. So can the academic setting be utilized for clinical trials to help lower costs? I think so. I'm not, obviously every clinical trial is different, but typically when a patient is enrolled in a clinical trial, they're really not fraught with a bill, right? The trial typically encompasses payment for the drug and payment for any ancillary labs or testing that's needed. Sometimes what can be challenging is transportation and hotel and, tolls and all of that may or not be covered. Some clinical trials have, stipends for patients that are traveling from far. How do you typically handle this at Dana-Farber?
Yeah, and cost is a consideration with trials. If anything, in some ways they can net increase costs a little bit rather than net lower them. And in my own experience, the goal of a clinical trial is to be cost neutral. And some people are surprised to hear that, many of the tests that are done in a trial, like if it's a scan that would have been done as part of routine care or a trial, it gets billed to insurance like normal. And then they try to bill anything extra that was being just done because of the trial to the trial. So the idea is it should be cost neutral, as if you were getting a standard treatment. In most cases, the drug in the trial definitely is being prescribed and being provided by the trial itself. So that can sometimes impact cost if you were paying a lot of out-of-pocket copays for other prior medications. But there's definite considerations around the cost of transportation back and forth. Some trials often offer small stipends or reimbursements for some of those transportation costs. And the further you're traveling for a trial, the more that consideration starts to pull up, right? Some people live in the same city as their major center and they're doing the trial right near home, it's very easy. If you live far away, there's all those issues of coming back and forth that really should be considered along with everything else when deciding upon trial options.
Definitely, but the most important thing is to just be upfront and candid with your team about that, because sometimes it can be very challenging when you're trying to get the patient on study. You know, you're like, you need to go here for the scan, then here for the biopsy, and this is happening in here, and you kind of lost in the momentum. And, you know, if someone doesn't speak up and say, hey, listen, I can't pay for this parking because this, or my dad doesn't feel comfortable driving across the George Washington Bridge, or whatever it may be, it's important to know these things. And please don't be shy and share those things with your care team so that we can address them and not let that be a barrier or a hindrance for you. And okay, in the interest of time, we have one last question, and then we're going to wrap things up. And this is really about legally and ethically giving advice on marijuana, which is still considered illegal federally. So I think this is a slippery slope kind of topic. I think there are certain states that have, medical marijuana approved and certain states that don't at this time. And it depends on what state you're on and depends on how comfortable the medical oncologist is that's caring for you.
Yeah, I would agree. It's very state specific right now in terms of what is available and what is considered appropriate. For example, in Massachusetts, we don't prescribe marijuana, so we are not able to, there's no prescription for it. A patient would simply choose to do that if they wanted to separately through a dispensary. But it's different in every single state, and it's something that you definitely would need to, needs to be carefully thought about depending where you live. This may be something that is more available or less available or still legal, depending where you're living.
Absolutely.
Yeah.
Well, we are right at the hour. This conversation flew. I appreciate your really candid, well-rounded answers and some little clinical pearls I've stolen from you about how to phrase things for my patients. So thank you. If there are any other pressing questions or issues that you have, please feel free to reach out to the LCRF team so that Dr. Rotow and I can get them answered. Thank you for the feedback. That's wonderful. We thank you all for taking this time out of your day to join and to ask such pressing questions and to get our wheels turning. So thank you so much.
Great. Thanks, everyone. It was great to be here today. Have a good day.